my slides. I'm going to speak to you on selective laser trabeculoplasty, and that's something which is not very, well taken in India, so to say. So many procedures we do, but we've been doing this for quite a long time. Oh, that one, no? Okay, sorry. Thank you. At the outset, I'd like to thank Chairperson of this session for providing me this opportunity, and Chairman Scientific Committee AIOS for letting me speak to you on SLT. So far we have got some publications from India on SLT, and many of it is in very, I would say, not, the labeled indication, so to say. So you have one in angle closure glaucoma, and then you have in juvenile glaucomas, and then a recent one from one of the alumni of SN. Anuj Sharma has come out in the Indian IJO 1 year outcomes of SLT in open angle glaucoma. So you have some publications, some activities going on. So, so coming to what would you like to do in SLT, in which eyes? So good gonioscopy is an important aspect. Because in India, as we all know, 50% of glaucoma is angle closure. We already know that. So you shouldn't miss angle closure and sort of take up the wrong patient for the procedure. And also angle recession don't respond very well to SLT. So that's a little bit no-no for that. Treatment naive patients are actually good for SLT. And if possible, try to stop the glaucoma medication as much as possible, because you are addressing a conventional outflow channel. So if the intraocular pressure is slightly higher, SLT works better. After the procedure, stop all glaucoma medication. That's been our protocol. We don't give any glaucoma medication, but of course, we always do SLT in very mild glaucomas, ocular hypertensives and OHTs. And if it's a moderate glaucoma, then we could always tell the patient that there may be some chance that you may be back on medication, but at least we'll stop it initially. Always expect a delayed response. So you can have a delayed response about 4 months later. So at that time, you have to handhold the patient. So we give sort of brinzolamide off and on. And because you could always switch it off and have a washout effect within 5 days, so you get back to the baseline pressure, so to say, and then you could restart it if necessary, if you want to handhold the patient in that manner. You could also use Diamox if the patient tolerates it well. And anticipate, like I said, that's why we give the medication, so anticipate intermittent intraocular pressure fluctuations. And the advantage is it can always be repeated. So, so medications have always been a mainstay, and now you have all these preservative-free medications available. But still, all these do cause, if they're prolonged use, you could have a problem. So far, we've been having a flash-pumped Nd:YAG laser to do SLT with. Now, something new is there. This is, I have no financial interest, but this is from the Zeiss group, and they have the diode-pumped orthoventilate laser. So this was, when we were speaking to some seniors, and they said you could use this as a cross-subsidization. So you have 2 machines, 2 different roles, but you could do one procedure because, for example, you could use a photodisruptor for your YAG capsulotomies and your capsular iridotomies, and then cross-subsidize that with SLT. Whereas the photocoagulator, you could do your PRP and then use that for your SLT. So you won't use so many SLTs. You won't do so many SLTs during your whole year, but you could always use it for cross-subsidization. So whichever machine you like, you could use that. The disadvantage with the flash pumped, it's not been documented very well, but the energy delivery is plus minus 20% of the expected. So that's something which you have to remember. Whereas if it's a diode pumped laser, the expected is energy delivery is 5% of plus minus. So this is how our machine looks like, and that's there in the clinic. And with the photodisruptor type of a device, as I mentioned, top right, you can see you can be cross-subsidized. You could use capsulotomy, iridotomy. With the photocoagulator, you could use for laser iridoplasty, laser iridotomy, pan-PRP, or you could use it for suture lysis. Post-NPDS, you could use for synechial release and such other activity. The important thing is when you use a flash pump, it's a single shot, a wide shot, whereas the diode pumped laser has 52 small spots. So they are micropulses, and they all get delivered in one go. The only caveat is you have to keep the trigger pressed till the whole energy is delivered. So the counter moves to the next one. Otherwise, the counter moves, but the energy doesn't get delivered. So that's something which you have to know when you use this machine. And this is the Zeiss SLT, and this is how it looks. And you have a sequence of 52 fast spots, and they also address the 400 micron area. you don't really see a cavitation bubble. If you want, you could increase the energy and then you see the cavitation bubble. And it's very safe, and efficacy is also pretty good. And this is what I mentioned that, and this is how it looks if you were to do it on a test. The 52 spot size you could see in that, and once you do it in a live patient, you could see the beam moving around. This is something like the carbon dioxide laser deep sclerectomy. If anybody has seen that, you would see the aiming being moving around, and then within that area is the laser gets delivered, all the 52 spots. So the titration is given by the company. So instead of using millijoules in the conventional SLT, you use microjoules. So if you have less pigmentation, you use 30 to 40 microjoules. Mild to moderate, you use 20 to 30 microjoules, and marked, you have 10 to 20 microjoules. You titrate. So we have great almost 2 to 3 pigmentation. So you use, our standard is about 24 to 26 microjoules is what we use. And this is how the machine looks, and these are all the features. And the advantages, you have something called the heads-up display. So as you're doing the procedure, you can see what is the energy level. You could increase the energy level, you could decrease energy level. All that happens without taking your eyes off the viewer objective lens, eye scope, sorry. And you could do all this with a trigger and a small button there. It's very user-friendly, and it's connected to the forum software as well. So all the data comes to your forum software. You could correlate it with the treatment and everything. So this is a small poster which we also put up. So this is objective is to assess the effect of SLT in over 2 years, and these are the inclusion criteria: open angle glaucomas, willing to sign the informed consent form, all secondary glaucomas, angle closures, and discretion of the treating physician where the SLT is unlikely to prove benefit, mainly, especially chronically medicated. So if the patient's been on medication for 5 to 10 years, we don't do SLT. And then this is the follow-up schedule at day 1, 15 day, day 30, sorry, not day 1, day 15, day 30, month 3, 6, and 12. And this is the protocol. And these are the results. So this is the baseline demographics. 68 eyes, main diagnosis of ocular hypertension and POAG. And untreated IOP was 22 millimeters of mercury. Pre-laser treatment, that is the baseline without medication when they first presented to us. It could be some time back, maybe 6 to 8 years, but that's where we recorded the data from. And pre-laser was on just one day, one hour or 1 day before the laser. And medications were 0.68. Mean deviation was minus 5.31, gonioscopically open angles, visual field index of 90. So this is the patients who should ideally do it. All patients are phakic eyes, so we avoid doing SLT in pseudophakic eyes. That's something which we've been following quite some time. And from a baseline or pre-op IOP, you have a not very significant IOP drop. It's 18.86. Clinically, it doesn't make so much sense. But if you were to look at it from the baseline of 22, you would have a significant about 3 millimeters, 4 millimeters drop of intraocular pressure. That's quite significant, mainly because many of our patients in this particular group were POAG on multiple medication. But if you were to take a treatment naive, I'm sure you get a different, better response. The visual field index did not change very much. And the percentage of IOP drop, more than 40, we had about 3 patients. And more than 30, we had 8 eyes. More than 20, we had 14 eyes. And more than 15, we had 18 eyes. So many of our patients were off medication. On medication, you see 0.68, and then they came down to 0.25. So it's a mixed bag. We are still exploring the options of how to make it work better, because the ability to deliver the laser we were not very happy with it, so we corrected it. So you have about a 15 to 20 millimeter IOP drop in this particular cohort. So no very much of adverse effects, only you have 1 hour, you have a little bit of flare cells which you see. But we should be careful not to start medication because of that. So we avoid doing that. The limitations are that number of patients off medication totally, we have not calculated that. We just looked at the eyes. And visual field was not done for all the 68 patients. 68 eyes, it's only for 47 eyes. So light trial, as we all know, it's having it's made a significant change. And we all know the data of that, of the patients who 94% of the patients were at target, and target IOP was achieved in 92% of these eyes. And in the medication group, 94% of eyes. and 93% of visits achieved target intraocular pressure. Drop-free control was 69% in the initial SLT group, and 90% of them had 2 SLTs. And if you look at patients who had a little bit of more advanced glaucoma, this is another meta-analysis where they studied 14 studies of 58, and they included patients who had, or rather, included patients who had no SLT or medication group, or non-randomized and other groups, and 13 were registered. So these were all excluded because they did not fit the criteria of the 58. So they did not include them, so they studied the 14 eyes, and they mentioned that the SLT demonstrated similar IOP control to medical therapy at most follow-up, along with comparable rates of target intraocular pressure, quality of life, visual field, and reduced rates of glaucoma surgeries, anti-glaucoma medication. So they support that SLT is effective and safe for open-angle OHT with favorable impacts on clinical treatment-related factors. So I'll stop here. Any questions, I'll be happy to take. Thank you.
Thank you, Ganesh. He's willing to answer questions.
Sure.
Very fantastic work, really exciting. I think you did say that you're just going to wait to define your technique.
Yeah, that's.
Yeah, my question was a little bit different. So, are you offering it as first line or
Yeah,
first line?
first line.
And how about the service pressure? Because it will always be widely prevalent. So, in the NHS in the UK, like first line is a little bit of like.
Yeah, so.
There are like 10 machines, but if you go to a smaller hospital, there aren't any.
So first line, I would say that we offer first line, but with the initial 1 month of treatment, we don't consider that as medicated. You don't have to consider that as a medicated IOP. You just reduce the pressure, and then you do the procedure. So you don't have to consider that because you're not chronically medicating the patient. You are using something to reduce the pressure. It could be even oral Dimox. Why do you think that if you treat the patient, it becomes not a first line?
I think the question is, does it have a pressure on your service? If everyone gets...
Can you cope with
Can you cope with the numbers?
Yeah, we could. I mean, I don't think this machine is particularly free the whole day.
Yeah. I think...
How much time does it take for one person's...
No,
10 minutes.
No,
10 minutes.
I think, I get where you're coming from. And actually, I think the way it should be the reverse of what Moorfields is doing. You guys should have the machines because they're seeing tertiary care. How many primary do they see who require laser, right?
We have machines. I think having multiple machines is like in a very big center is possible.
Yeah. So that's...
Also, some patients may not want it as first line.
Absolutely. That's true. So we have patients who take treatment for the one eye, continue medication for the other eye, see the response for one eye over the year, and then come back for the other eye. So that's a cohort of patients who do that as well, especially if they have some medical background, they know.
Can I ask you, how many do you schedule in an hour, SLTs?
So normally, on a half-a-day list, you'll be doing about 12 eyes.
Okay.
Yeah.
To it. It's not, because it's not just doing the...
Yeah.
We don't have assembly line, so it's,
Right.
you have to see the patient, consent them, check the
Yeah.
pressures, and then...
It's just a different...
Yeah,
So-
I know. So that's the reason there's no pressure here.
Yeah, there's no pressure here because the machine is invariably free the whole day. We do about 30 eyes per month.
And thankfully, we have got allied health professionals, so our trained nurses to do it, and they have to do it better than us because they're doing it day in and day out.
True, and the person who is appointed to do SLT is sitting free the whole day. I got a manpower there sitting free the whole day. The doctor, he's dedicated for that, but there's no patient.
Yeah. So I think we're more or less out of time. Thanks to all the speakers and thanks to the audience for sticking through till the end, and thank you.